Thank you so much, ladies and gentlemen, and I must apologize that I clearly speak the wrong language here. I didn't ever learn Spanish. I learned German because of my interest in music and physics, but boy, do I wish I knew Spanish. First, I must thank Greta Macilon very much, my excellent tour guide. She has taught me a great deal of history, pre-Columbian history and Mexican history, and having grown up in Texas, of course, I was completely ignorant of most of it, although I did learn some in the school, and I've really enjoyed the last few days, and thank you so much for attending my presentation. Next slide, please. So we had a little scramble backstage to get these slides up, and I should applaud the staff for really getting it up for us. So I'm going to talk to you today about cardiovascular disease. This is a very important disease in that it's the top 2 causes of death and disability worldwide. The 2 are ischemic heart disease and stroke. One affects the heart, the other affects the brain. It's very important to me today. I can share with you that one of my postdocs, who is only in her 40s, she has a 12-year-old son, she suffered a stroke this morning and will likely die. So I will use this opportunity to ask all of you to pray for her family. So this accounts for 30% of deaths in the United States, and it also accounts for about a quarter of all the deaths in Mexico. It's a very important problem for us to help solve. Next slide, please. So I'm going to talk to you about 3 different targets today. They're physiologic targets. One are thrombi, or blood clots. If they are in the brain, they cause a stroke. If they're in your heart, it's myocardial infarction. If they're in your lungs, it's called pulmonary embolism. And if they're in your legs, it's called deep vein thrombosis. Those clots are very, very important because they block blood flow. And particularly for the clot in your brain, you have 3 hours to get rid of it. If you don't, the brain dies. So the second target is the brain specifically. I'm going to talk about drug delivery in order to protect the brain, neuroprotection during stroke. And last, I'm going to show you a glimpse of some ideas in order to treat infective endocarditis. These are the valves. The major valves in your heart can get diseased. And when that happens, the valves don't work, the blood doesn't flow, and there's ischemic tissue, or tissue without oxygen. Next slide, please. So usually, when you put drugs in the system, it requires very high doses, because then the drug circulates. You're competing with the reticular endothelial system in order to take the drug away, in order to get the drug. So I'm interested in getting drugs to the clot to break it up fast, to the brain during stroke to protect the brain, as well as to the heart valves during infective endocarditis. Next slide, please. And what we do is we encapsulate drugs or bioactive gases in a liposome. So the liposome, my pointer is very light. The liposome is surrounded and protected by a lipid bilayer. That's the definition of a liposome. There's a hydrophilic space in which you can put drugs. Here I've shown TPA, or tissue plasminogen activator. So this is a thrombolytic drug, a drug that breaks up blood clots, and it does so by activating plasminogen in the human bloodstream to form plasmin, which cleaves the fibrin mesh. Okay? So we can also have a little bit of the drug on the outside because it targets clot as well. And my last interest is using these bubbles for several reasons. One, because they're highlighted on an image. It's image-guided therapy. You can see where they go, then you see where the drug is. Once you excite this bubble into volumetric excitation, it pushes out this membrane and releases the drug. And lastly, it enhances the diffusion of the drug through kind of convective fluid motion around the bubble that's moving. So the bubbles usually has 3 purposes: to see where it goes, to deliver the drug, and to enhance the drug uptake. All 3 things. Next slide, please. So we put this kind of molecular Velcro on the outside of the liposomes in order to make it seek the target that you want to seek. If you have TPA, it's going to stick to a clot, for instance. But we've tried a lot of different ways of doing it, including antibodies, ICAM1 to target atheroma, and lastly, inactivated TPA on the outside of the echogenic liposomes in order to target fibrin itself. Next slide, please. So this is a video, and you can see the whole concept is we put the drug on board, and Once ultrasound hits the liposomes, that's when the drug is released and hopefully goes to the target. Next slide, please, and you can go ahead and run the video on that page as well. So on a close-up within the lumen of the vessel, you can imagine this is a picture, a cartoon of a non-targeted liposome. It releases its payload once it's hit by the ultrasound. Next slide, please. So we've used some very fancy equipment at Erasmus University. This is the Brandaris camera. It can take 25 million frames per second under a microscope. And we've learned a lot about the acousto-mechanical properties of the shell protecting the liposomes by looking at the way these liposomes move dynamically as they're exposed to Doppler ultrasound pulses. Next slide, please. And so this is a video from this camera where you can see a single liposome, and then that's one pulse. So from that one thing, we can do a lot of math and learn about the elastic properties of the shell. So if there's a student in the audience that can tell me something they see, go ahead and play the video again. What do you see in this video? Anybody? Yell it loudly. You have to be a student, though. I hear the front row here. Come on, just yell it out. What do you see?
It's kind of expanding and then explode.
It expands and contracts. And how about the size at the end versus the beginning? Oh, it's bigger at the beginning and smaller at the end. Okay, so we call this acoustically driven diffusion. So you're using acoustics to drive the gas each cycle out of the liposome. So because of that, I'm interested in delivering bioactive gases as well, and we'll talk about that a little bit later. So, go ahead, next slide, you're fine. Yvonne is my expert slide projector. Okay, so it's a team effort today. So, in my lab, the way we know what the bubbles are doing dynamically is we simply listen, just like you're listening, right? We listen to the sound of the bubbles entering the primary therapeutic field. And when you have a low amplitude, go ahead and push advance the next one. Low amplitude, go ahead, click again. You see that you have this gentle pulsating or stable cavitation, we call that, because it's temporally stable. And when you have stable cavitation, it's going to generate the bubble motion is so nonlinear that you get a subharmonic and you get ultraharmonics, which are multiples of the subharmonic. You also get the fundamental and multiples of the fundamental. Those are the harmonics. See? Music. Now you understand why I majored in music and physics. Okay? And then with inertial cavitation, you saw that where there's this huge, very rapid collapse of the bubble, and it collapses so rapidly, it's an adiabatic collapse. Isothermal expansion, adiabatic collapse, and you get this broadband noise from it. So I can tell the difference between inertial cavitation or destructive cavitation versus stable, temporally stable cavitation just by listening. So the next slide, I have a video with sound. Hopefully you'll be able to hear it. On the left, you have inertial cavitation. Sounds raspy. And on the right, you can see very large excursions of the bubble radius. And that's stable cavitation. You can hear that subharmonic, and that sounds more like an oboe. The other one sounds more like a raspy kind of noise, right? Very easy then to tell the difference. So what I did is I moved the fundamental from ultrasound frequencies to middle C on the piano for you. That was the trick that I did so you could hear the difference. Okay, next slide, please. So I want to apply these concepts in order to break up blood clots very quickly. Next slide. And so this is an SEM of a blood clot. In fact, it's probably my blood. And you can see there's this fibrin network. That's the structure, the scaffold that holds the clot together. And then you can see platelets and red blood cells, right? So it's a whole blood clot. Now, next slide, please. What happens is a clot gets stuck in the middle cerebral artery, either side, either on the right or the left. And or out along the branches, and depending on where the clot is stuck, that part of the brain is affected, and then you'll see different symptoms of the patient. Facial droop, right, is one. I'm going to tell you how to diagnose stroke. Facial droop is one. Asymmetry in their gait or ability to move. FAST is the acronym in English at least. So facial droop, asymmetry, loss of the ability to talk, right? All of these things tell you that somebody's having a stroke, and it is an emergency when this occurs. Bring the person to the hospital immediately. If people stop talking, it's hard to know what's going on with them. So if all of a sudden, and sometimes old people don't talk that much too, so you won't notice. Please notice and bring your mother or your father or your grandmother or your grandfather to the hospital right away. It's very important. It's an emergency. Next slide, please. So what we want to do is we want to get rid of this clot very quickly. There are two types of stroke, ischemic stroke and hemorrhagic stroke. Ischemic stroke is more common, occurring in about 83% of the patients that present with stroke. And, oops, back we go. I forgot I could advance. Okay, okay. So, Yvonne, I just forgot that I could advance. We're fine. So what happens is you get, it's a stroke, and what we're doing is there's two different therapies. Recombinant tissue plasminogen activator, that's the drug. It's a pretty nasty drug, has a lot of side effects. And the other one is mechanical thrombectomy, where you snake a catheter from the groin all the way into the brain and mechanically catch the clot and pull it out. Okay, so there's two types. Next, let's see, I can do it, never mind. So what I've done is I've designed this transcranial ultrasound system that can essentially insonify the entire sector of the brain where a clot is likely to occur. And what we do is we release the TPA from these liposomes, as well as try to enhance clot dissolution. Let's see, this slide. So first, let me tell you a little bit about these echogenic liposomes. If we size them in a Coulter counter, multi-sizer 4 by Beckman Coulter, we get this beautiful size distribution as a function of diameter. And you have number weighted on the left in gray, and volume weighted size distribution in right, that's in the black line right there. And then a second system that we've done in the lab is, we call it attenuation spectroscopy, where we have a pair of opposing PVDF hydrophones or microphones underwater, and by measuring pitch catch, there's a through mode excitation, we can measure the attenuation as a function of frequency between 2 megahertz and 25 megahertz, all in one measurement very rapidly. And you can tell, because this is medical physics, it involves the body, we have to do this at 37 degrees rather than body temperature in order to be accurate. So the attenuation increases as a function of temperature, and you can see there's kind of a sweet spot. So it's a quasi-resonance. So if you wanted to break the bubble, you would hit it at that resonant frequency in order to deliver the package. Okay. So we're also extruding these because of that resonance phenomena in order to get a monodisperse. You can tell they're quite polydisperse in size, right? So what we want to do is tighten that a little bit more by using microfluidics. And we've had some success in essentially loading TPA. So here, green is highlighting the TPA, yellow is the lipid, okay? So, and red is the phospholipid shell. So it's really kind of fun to do these things. And then with the multi-sizer 4, you can see we have a much narrower size, tight size range, and a very sharp peak in terms of the resonance frequency. So this is exactly what we want. And now I want to show you how some experiments we did to see the mechanism of enhanced thrombolysis. And we can posit that there are really two. One is radiation force, and the other is acoustic cavitation, right? And I want to show you a bit about both of them. So what we do is we capture a blood clot on a silk suture. Silk is embolic. It causes blood to clot. So it's a great way to hold onto a blood clot in flow. And it's about maybe 300 microns across. So tiny clot on a silk suture. We then put it into a flow system, and we then expose it to 120 kilohertz, or now we're up at 220 kilohertz ultrasound, and we simply listen with a passive cavitation detector of the sound the bubbles are making, okay? So this is kind of a classic experiment in order to see and hear the bubble activity. So we can then race the different therapeutics from this kind of intermittent ultrasound scheme, 50 seconds on continuous wave, 30 seconds off. I'll tell you a little bit about why we do that in a minute. And then we can race the different therapies where we have human fresh frozen plasma, or we have TPA in human fresh frozen plasma, or an echo contrast agent, bubbles, and TPA on the outside. So here, the TPA is not loaded on the bubbles. We just have an FDA-approved drug and an FDA-approved echo contrast agent. Quicker to clinic if you do it this way, right? So we essentially have this scheme that you have it on and off, on and off. The reason why we do that is because cavitation is episodic, and it peters out after a while. It stops after a while. So you're better off turning off the sound, letting the DEFINITY flow in again, and turning it back on. So that, in this particular case, the optimal way was 50 seconds on and 30 seconds off. We detected the cavitation by simply listening and doing signal processing in order to look for the specific ultraharmonic bands that I talked about that you heard, or somewhere in between the harmonics and the ultraharmonics in between, where it's essentially the noise background increases for that broad band. So we can differentiate between inertial cavitation and stable bubble activity or stable cavitation. So under the microscope, this is what you see. Clearly it's a shadow graph, and we can essentially do image processing to look at the width of the clot as a function of time in order to get an idea or a concept of lytic rate quantitatively. So the faster that clot dissolves, the higher the lytic rate. We can also track the center position of the clot. If you're going to have radiation force that moves the clot, right, then you can just simply look for the root mean square velocity of the clot in order to get an idea of the effect of the radiation force. So we quantify both of these things. Now I'm going to show you a movie. Go ahead and run it, Yvonne, if you would, where what's plotted is the energy in the ultraharmonic, it's in millivolts squared, as a function of time. You can see when the sound is active, you see these bubbles, and when it's not, they're quiescent. Some of the bubbles survive from pulse to pulse, and boy, is it effective. Now there's TPA and plasma coaxially running from the bottom to the top. So this is a beautiful way to see essentially the effect of bubbles, DEFINITY, on TPA lytic efficacy. And so if we do many, many runs like that, and we race at different concentrations of TPA, we're at 3.15, that's the clinical dose. That's what you would get if you went into the emergency room. So, and here you can see you get similar efficacy even with much lower dose because of that bubble activity enhances the diffusion. So this is straight diffusion problem, and you can see you have very little endogenous TPA in the plasma, so you don't get much activity if it's just plasma alone. So now I want to show you the effects of, well, the other thing I can tell you is the higher the amount of bubble activity, the higher the lytic rate. So we want more of that bubble activity in order to increase the rate of lysis. So now let's look at radiation force. So once again, we have a shadow graph of the clot where I'm plotting ultraharmonic energy as a function of time as the sound is going on and off. And this particular clot, you'll notice, is highly effective. You can go ahead and run that movie, Yvonne. Very particularly sensitive to radiation force. When the sound is on, the clot shifts to the right. You can tell the sound is coming from the left to the right? So the title of that paper was Shaken and Stirred, just like Bond, right? We're getting both shaking and stirring from the bubble activity. So you can see that the more the radiation force, the higher the lytic rate, again with the different doses. So, the more of the shaking of the clot back and forth, the better the lytic rate is. So now you would think, oh, this is great, patent's launched, the company has licensed the patent, now we'll have a great transcranial system, except as we went into animals, we always learn things, right, when we do preclinical work. And it turns out that not all clots are created equal. And by that, I mean some clots are very soft, they're pliable, they're erythrocytotic, they have a lot of red blood cells. Some are very fibrin enriched, those clots that have probably been in the heart for many days, if not weeks, if not months. They're highly organized and fibrin, and they're very stiff, right? So, unfortunately, the two clots have very different interaction with TPA. So, highly retracted stiff clots are plotted on the left. You can just, instead of looking at the lytic rate, we can also just treat a clot in static fluid, measure the mass loss as a metric for thrombolytic efficacy. That's what a physicist would do, right? How much of the clot went away. And for retracted clots, you can see TPA alone and TPA plus Definity plus ultrasound, not much difference at all. In fact, hardly a statistical difference between TPA alone. It's ineffective, that drug, against very highly retracted clots. Or the very soft erythrocytotic clots, unretracted clots, that's the type where TPA works and ultrasound really helps. Okay, so now we know that there's a problem. It depends on where the clot originated. Unfortunately, then the next step was even worse, because porcine clots require higher TPA concentrations to affect thrombolysis. You can see that in order to convert from plasminogen to plasmin in the presence of soluble fibrin, it must be human soluble fibrin, not porcine, right? So you need human soluble fibrin or porcine soluble fibrin in the presence of human plasminogen. So here I am with lots of funding in order to go into pigs, and yet I learn that porcine clots in the porcine circulation is not a very good metric for human clots. So it is. So our approach is to create porcine clots the same system with the lytic rate on the clot on the suture model. And now what I'm going to do is I'm going to show you data where we used human clots, human plasma, or human clots and porcine plasma, so it's cross-species. Or porcine clots in porcine plasma, or porcine clots in human plasma. So now you can see I'm setting up to see if we can use human clots in the porcine circulation or not for our test. So we did the same thing, the same clot on the suture microscopy, and here's plasma alone, here's the TPA treatment, here's TPA plus ultrasound plus Definity, right? So first of all, human clots works great, right? You have this huge enhancement, lots of extra diffusion, and ultrasound enhances that thrombolysis. However, TPA alone in the porcine clots doesn't work at all. Doesn't work, nor does ultrasound enhance it, because really, 10 times 0 is still 0. So if you have no TPA, you have no enhancement, right? But you can see there's hope. So there's hope. If I have human clot in porcine plasma, there's hope, right? So that makes sense. Now let's look at SEM. So you can see the structure of the clots in human clots and in porcine clots is completely different. The human clot is much more porous. That's probably the TPA acts on this fibrin mesh, right? And so that's really important to try to enhance diffusion. You have to get the TPA there to start with. And it has to be efficacious. You have to convert plasminogen into plasmin. So I'm now working on two different models using human clots in the porcine circulation. One is in the ascending pharyngeal artery of a pig. We trap a clot just before the rete mirabile. This probably translates to Spanish better than it does to Latin or English. This is a tangle of vessels. Pigs are ruminant, so they spend a lot of time with their heads below their hearts. And that's probably in an impedance matching system in order to keep all the blood from going into their heads while they eat all day and find food. So we can't simply give a clot in the middle cerebral artery of the pig, so we do it in the ascending pharyngeal, which is just extracranial. The nice thing about pigs is they have thick skulls just like people do. That's why we don't use dogs, right? Pigs are a good model. The other one is for hemorrhagic stroke. And this is when you have a bleed into the brain parenchyma. It's also an emergency, and we're doing this in a juvenile pig because the bone of a juvenile pig has the same thickness of the temporal bone of humans. Okay? So, now I want to talk to you about protecting the brain with bioactive gas. So it turns out xenon, a noble gas, that's used for all kinds of different commercial things, also has antiproteolytic properties. It's a neuroprotectant. It rapidly diffuses across the blood-brain barrier. It's inert, and it essentially blocks the excitotoxicity of ischemic neurons. Those are neurons that are devoid of oxygen. Problem is, it's kind of like a neuron is like a kid in a candy shop. If it doesn't have candy, it dies. But the minute it goes into a candy shop, it wants to eat too much candy. That's what your neurons do. They eat too much candy, they eat too much oxygen, and then they get kicked into apoptosis, or this programmed cell death. So what xenon does is it blocks that pathway to apoptosis. So it's neuroprotective. If you just get a little xenon into the brain on the way to the hospital, then you might be able to protect the brain a bit until you can remove the clot. So it buys time, essentially, for the physicians and surgeons to deal with the problem. The concept is very similar where we do these bubbles. So instead of having a drug in the hydrophilic space, we're using the hydrophobic space, the gas, in it. So the concept is we have two different recipes, essentially. One is classic liposome, where there's not much in the hydrophilic space, but in the hydrophobic space, we use a combination of xenon and octafluoropropane. That's a perfluorocarbon gas, a very heavy gas. And it turns out, for those of you, how many of you have taken thermodynamics? Please, everybody raise your hand. I feel like I'm at home. Yes, okay. This is the course that most of us think we'll never use again. You'll use it. Pay attention, okay? This is a course I thought as a student I would never need. Boy, was I wrong. I need it very much because this is the crux of this patent. Because the diffusion of gas out of that bubble is driven, right, by a lot of things. One is the solubility of the gas in the fluid, the bloodstream around it, as well as the weight. It turns out perfluorocarbon is very heavy, insoluble in the bloodstream, and so it wants to stay in the bubble. And it actually cages the xenon for a little bit longer. It's amazing, right? You would have never guessed this. So we do the same thing, only we get rid of the lipid bilayer. This time we only have a lipid monolayer. You can pegylate it to keep it from getting flushed out of the system by your kidneys and liver, by the reticuloendothelial system a little bit longer, just like most liposome work, right? So you can pegylate, light pegylation, and we have a combination of octafluoropropane and xenon. Okay, so what you do simply is in the carotid artery or in the brain itself, you would release the xenon. It would then travel and protect, be very neuroprotective. Okay, so again, we use this attenuation spectroscopy and we use the Coulter counter to look at the size distribution. On the left, you see xenon microbubbles, and on the right, you see xenon plus octafluoropropane microbubbles. So first of all, you can see, once you put octafluoropropane, and the way we make these is through an amalgamation process, where you simply put the gas in the headspace of a gas-tight vial, the lipids in the bottom, and you shake it, right? And this is just how Definity is made. It's the FDA-approved echo contrast agent, only we add a little bit of xenon in the headspace. And when you do, it's very echogenic, and it's also very stable. If you put, it doesn't matter if you have a xenon-saturated solution on the outside, or air-saturated, or an undersaturated, similar to the venous system. You can see they're very robust, and the gas stays associated with the microbubble. However, if it's 100% with no octafluoropropane, you kill it the minute you put in undersaturated in the venous system. So this is essentially data showing why you want to use a combination of octafluoropropane gas and your bioactive gas. So we can test the attenuation in the same system, right, that I described before. We have a reservoir. You can hit it with ultrasound to see if we can deliver the gas. We have a transmit and receive pair of opposing PVDF hydrophones and do the calculations to give this data. So you see attenuation from 2 to 25 megahertz, xenon alone at 0 minutes and then at 20 minutes. So they lose their gas over the time, and this is in fully saturated solution, versus xenon plus octafluoropropane microbubbles, and you can see they're very robust, and even after 20 minutes, all but maybe 20 dB, resonance still survives. You only have to beat about 3 minutes in circulation, by the way. So 20 minutes is well beyond what you need in order to deliver the xenon. Unfortunately, though, in undersaturated PBS, only the xenon and OFP microbubbles survive, right? It just kills it. So now I want to see if I can release the gas using pulsed ultrasound. That's the next step. Now, first I've proven that I've got xenon in there, and so now I want to see. So this is exposed to 6 megahertz duplex Doppler, so at a very low amplitude. This would be typical of, you know, some kind of carotid ultrasound system, right? So if you have no ultrasound, there's the blue. If you have a bit of ultrasound, it turns out it's even a little bit higher, but it's still very echogenic. And if I turn up duplex Doppler, the mechanical index, which is an indication of the acoustic pressure, then you can deliver the gas, okay, for xenon. And the same is true for xenon plus OFP, right? So with B mode alone, you can't break them, and with duplex Doppler, you can break them. How about that transcranial system I showed you that operates at 220 kilohertz or 120 kilohertz? We have the same sort of behavior where without ultrasound, you can see nice robust attenuation, and with ultrasound, it just dies. The same thing with OFP and xenon microbubbles. From 2 to 25 megahertz, you get this nice delivery of what is on the interior with ultrasound exposure, okay? So, this is how much. We've used GCMS to see how much xenon is in this. This is well beyond what you need therapeutically, so it was very good news. And so, despite putting just 10% OFP in these microbubbles, so you actually get even more xenon in the within the liposome. Actually, this is not a liposome, it's a monolayer within the microbubble. So this is actually very good news. So now you might say, well, what happens if you put these in animals? So in a rat that has an occluded artery, so we've essentially taken the internal carotid artery of the rat and we've occluded it for a period of time and then released it afterwards. And what you typically see is an infarct, so this is dead tissue, right? So this is TTC staining of the brain, and dead tissue occurs when there's no treatment. Even if you have xenon-loaded liposomes, these echogenic liposomes without ultrasound that's delivered intra-arterially, you can see there's much less infarct volume, right? So then you might say, well, can you just saturate saline with xenon and push it in IV? And it does help a little bit, not a lot. Or xenon-saturated saline with ultrasound, so I'm showing you all the controls, or you only have a 48% infarct volume reduction if you have xenon-loaded echogenic liposomes with ultrasound given intravascularly, so that's IV, or that's without ultrasound and with ultrasound, you have a 75% infarct volume reduction. So that's in rats, using an ischemic stroke arterial occlusion model. If you want to see what it is quantitatively, this is essentially the numbers that I showed you on the previous slide in pictures. You can see that you really get the best therapy with the echogenic liposomes plus ultrasound, and we delivered the echogenic liposomes in the tail vein of the rat. Okay, so how about other types of stroke, such as subarachnoid hemorrhage or subarachnoid hemorrhage, SAH, right? So this is the kind of hemorrhage that you'll see if you just poke a wire and essentially cause the hemorrhage in a rat. I apologize, this is just before lunch. You'll have to forget these pictures when you eat your lunch. And so if you if you give echogenic liposomes or xenon-saturated solution, it reduces the infarct size from the subarachnoid hemorrhage. Okay, so we've demonstrated it in rodent models. We're very interested in doing this in pig models next. So you can see this xenon-loaded echogenic liposomes, you get this reduced hemorrhagic volume just because you're protecting that part of the brain. You can't protect the part of the brain that is affected and dies before resolution of the clot, but you can essentially protect the penumbra, it's called, the tissue that's around the clot, and you'll protect that. That still saves quite a bit of brain tissue when you do this. So lastly, if I have time, I want to talk about infective endocarditis. So you can see the games that I'm playing are with enhanced diffusion with bubbles into an area where there's fibrin, and it turns out this happens in endocarditis. The vegetations on the heart valves essentially have fibrin as the backbone of the biofilm. So it's a very important problem, particularly for IV drug abusers in the United States currently, and it also happens from, just small peripheral surgeries that occur, or dentistry, where bacteria are introduced into the bloodstream. They then set up shop on the heart valves. They protect themselves with this biofilm and rendering it completely impervious to antibiotics, such as oxycillin or, just regular antibiotics. So the most common cause of infective endocarditis is Staph aureus. So this is what I used for this particular model. So this would be a picture of what biofilm looks like. You have this, large amount of microorganisms present, right? They're in their dormant metabolic state, which makes them not really susceptible to antibiotics because they're sleeping, essentially, the bacteria are. You have this lack of an effective immune defense because of it, very poor antibiotic penetration because of it's a fibrin mesh around it, and then there's this development of resistance to the antibiotic because of it. So if I were to show you beautiful histology slides, you would see, using H&E and crystal violet, you can see that there is fibrin, that's pink, red blood cells are red, bacteria are purple, right? And again, on crystal violet, you have the purple bacteria, fibrin is yellow, and the red blood cells are brown in that particular slide. So it's just up my alley in terms of my interest. So what we did was we essentially inoculated our whole blood clots, human whole blood clots on the silk sutures in Staph aureus. And we set up a very nice biofilm on the outside. So here you can see, this is an enhancement. This is the silk suture, that's the bacteria. These are all H&E stained, and here's the blood clot, okay? So you might say, well, okay, Christy, I see the bacteria, but is it living? Yes, this is a live dead stain. Okay, so this is green nucleic acid stain, which is live, and propydium iodine stain, which is red. So the red are the dead bacteria, and the green are the live bacteria. In my clot model, they're living. Okay, so we have living Staph aureus. Exact same system I showed you before. We put the clot in flow, right? And we can race different therapies with and without ultrasound, with and without antibiotics, and TPA, right? So here's the combinations that we did: plasma, RTPA, oxycillin, Definity, okay? So it's very similar, and what we did was, now this is a very complicated slide, I apologize, but we took a lot of data. So plasma in every single one, TPA in this one, antibiotic in this one, ultrasound in this one, and microbubbles in these, okay? So you can see the most effective therapy was when we had all on board, right? And this has to do with some of, we were trying to learn about our clot models as well, in the red on the right. But that's very interesting. So you might say, well, what do they look like under a microscope too? So this is one run where we did not get complete loss of the biofilm. So what's up with that, you might say? So we might want to take a closer look at that. And here you can see, what's nice is if we did it not in black and white in the shadow graph, but if we did it in color, I can see beautifully, I can see in yellow the biofilm as opposed to the clot, as opposed to the silk suture, right? All three are very clearly highlighted in this image. So I'd like to do further studies, obviously, in order to try to optimize this type of therapy for infective endocarditis. You might ask, well, what goes downstream? Because if you liberate the bacteria, they come out of their dormant state and they'll be much more susceptible to the antibiotic. But what if there's big chunks of fibrin? Does that cause problems downstream? With ultrasound on board and TPA and bubble activity, the answer is there is nothing that's even the size of a red blood cell. It's pulverized going downstream. Okay, so it's very effective. Given a very low amplitude ultrasound and bubbles, you're just aiding diffusion, and it matters. When you can get the drug where it needs to go, enhance the uptake of the drug in the biofilm, and then liberate the bacteria, right? Nothing bigger than 8.6 microns. So in summary, I essentially have shown you a number of in vitro models, including the one for infective endocarditis. I've demonstrated that you can essentially break up the blood cells with ultrasound and bubble activity. I've shown you that we can packaged the whole thing in a single liposome, and that we're very hopeful for the next stage of pig studies. So I'd have to thank my lab. Okay, this is the group. Unfortunately, this is the young woman who this morning suffered a very devastating stroke. Please pray for her. And lots of people helped take this data. I have faculty collaborators. This is David McPherson, who's the Chief of Internal Medicine at UT Health Science Center in Houston, Texas. And Xiaoling Huang, she is the expert, liposome expert who helps us make the echogenic liposomes. Jack Rubenstein, he's from Mexico City. He's the one that said, you've got to go to Puebla. So we can thank Jack for having me here. And Klausina Koyman and Kevin Hayworth are both junior faculty that I really enjoy working with quite a bit. Thank you very much for listening.
Thanks very much to Professor Holland. We have time for some questions. Tenemos tiempo para preguntas.
Ivan he has offered to translate, so step up to the plate and ask it in Spanish, it's fine, doesn't matter.
Pueden preguntar en español.
Have you evaluated the risk of the treatment, of some of these treatments?
I'm sorry, I can't hear the sound system. Can you repeat your question, please?
Have you evaluated the risks of these treatments?
Yes, I wanted to stay on time. We've done a lot of histopathology in the porcine brains, doing lots of different images to see if we cause damage with the ultrasound alone, for instance, with no TPA or with TPA and ultrasound. And so far, there's no extra damage. Of course, this is a situation where it's a devastating problem and there's lots of damage just because you have a blood clot in the brain. So we see that damage for sure, but we don't see any added damage because of the ultrasound. We're using very low amplitude ultrasound, much lower than diagnostic ultrasound, to be honest with you. It's on longer because there's CW, but we haven't seen any problems with heating. We actually, for the first pig, we did see skin burns because of the deposition of ultrasound energy in the skin. But then we developed a cooling system for the transducer face. It was from self-heating of the transducer. We were driving the transducer, but that's the only thing that we've seen is a skin burn, to be honest with you. It's in the throat of the pig. Turns out the ascending pharyngeal artery is here, so we use this actually through the roof of the mouth in the pig is how we're doing it in the pig studies. It's a good question.
Hi. What's the average time to decrease hemorrhagic volume and clot volume?
For hemorrhagic stroke?
Yes.
The problem with that is there's no real way to reduce the volume. Well, first you have to stop the bleeding. That reduces the volume, and you usually do that neurosurgically. And the concept here would be to enhance and liquefy the clot and then aspirate it. So it still requires neurosurgery for hemorrhagic stroke. So one of my collaborators is the chief of neurosurgery and is a stroke expert. His name is Mario Zuccarello. And so he does these surgeries where through a borehole, essentially, you would then aspirate the clot. But first you liquefy the clot so it's not solid, so that you can remove more of the clot. And if we could have some of the xenon on board, we would protect the penumbra, the brain tissue around the clot. First thing you need to do, though, is to clip the aneurysm, or they do it also through the groin now. You can essentially stop the bleeding from within the vessel. There's all kinds of wonderful devices that are used intravascularly to stop the bleeding. There's glue, there are stents, there's all kinds of coils that you can do to essentially stop the bleeding from an aneurysm particularly.
Second question, how much time it takes to liquefy it?
Yeah, so for all of the studies that we've done, we use a half an hour as our metric, our litmus test, because we think if you can't do this within a half an hour, then it's of no use, because it's too late. Really, you have 3 hours to save the brain. So it oftentimes takes quite a bit of time for family members or friends to recognize stroke as an emergency and to bring the patient into the emergency room. And then it takes a while to evaluate, to differentiate between hemorrhagic and ischemic stroke, because you would not usually put TPA in the clot of hemorrhagic stroke. First you have to stop the bleeding, and TPA does the opposite, right? So first you stop the bleeding and then you would put TPA in for your particular question for hemorrhagic stroke. The nice thing is the xenon, you don't have to know whether or not it is hemorrhagic or ischemic. It helps in both. So this kind of therapy would be done in the ambulance on the way in. Doesn't matter. As long as you confirm stroke, then you would put xenon on board before it gets there.
So it works perfectly to an extremely emergent situation?
Yes. Yes. The answer is 30 minutes, essentially. All the data that I showed you was 30 minutes. 30 minutes only. We stopped after 30 minutes. So if you saw an ineffective treatment, it's because we stopped at 30 minutes. It might have been more effective if we kept going, but we kind of decided a while ago that if we can't make a difference in a half an hour, then it's kind of futile for the patient. And so we're racing time. Time is brain in stroke. We have another question down here.
Yes. Can you use this treatment to break up any other biomolecules?
To break up, yes, okay, so good question. I haven't tried anything other than fibrin and clots. I'm in cardiology, but I would guess that it would work. I've recently gotten funding for a much different regime of ultrasound. It's called histotripsy. You've probably heard of high-intensity focused ultrasound, where you essentially ablate tissue at depth using thermal deposition of the field, the sound field. That's HIFU, or high-intensity focused ultrasound. If you turn the ultrasound up even higher, and I'm talking 110, 120 megapascals, peak rarefactional pressure, that's really high, then you vaporize tissue at depth. And I'm trying this for deep vein thrombosis. I clearly didn't want to try to deal with the phase aberration correction of the skull. So we're doing it in tissue in the legs for deep vein thrombosis to literally vaporize tissue at depth. So this would be surgery without having to cut open a patient. I think it's very exciting. It's being tested clinically for prostate cancer now. I'm trying to apply it for deep vein thrombosis with a colleague who's at University of Chicago. He trained with me. His name is Ken Bader. So we're also in clots, but I could see that you would use it for cancer as well. I'm not an expert in cancer. I haven't collaborated with any experts in cancer yet, but I could see that it would be used at high amplitudes. I could see how even at low amplitudes we could use it to try to push drugs into the center of cancer that is devoid of blood flow as well, into the more ischemic portions of cancer tumor. But so far I haven't done it. I've stayed where my comfort zone is in the cardiovascular system.
Hi, what is the shelf life of the xenon bowls?
Of the liposomes or the microbubbles?
The
Yeah, we
microbubbles.
haven't completely studied it yet, but so far so good. You know, the lipids are not exactly stable for a long time, and so that's what you worry about is lipid. So far, most of the data we've taken are within 3 months, but in order to do, you know, the full GMP, we'd have to see if the shelf life all the way out a year or two. But so far, so good. The lipids are what worry me, right? The degradation of the lipids.
Okay, thank you.
How do you model or predict the resonant frequencies of the bubbles?
So the modeling is all done through an equation called the Rayleigh, Plesset, Noltink, and the Pyrus equation. It's the wave equation. It's a very nonlinear equation. And so a lot of my publications, if you look them up, is in modeling the bubble dynamics due to this very highly nonlinear behavior. And I was asked, and all of you students out there, this is my highest cited paper was when I was a postdoc fellow, not now. It's usually when you're young brains. So take your work very seriously. And I essentially did an approximation to that equation. And when I got a phone call from somebody from NEMA and AIUM because they wanted to change essentially how the output of diagnostic ultrasound equipment was done, I simply applied this model and got an answer, and the answer is the mechanical index. You could see that I even put the mechanical index. It's on every ultrasound scanner in the world now, and that was a paper I wrote when I was a postdoc. So, you know, if you think you're doing theoretical modeling, it's very important. Recently, I've done the same thing for histotripsy with Ken Bader and I. We repeated this approximate estimation of the RP-NNP equation for histotripsy pulses, where you have these just huge rarefactional. We had to change the approximation a little bit, but we got this nice relationship. So it will help predict exactly where you would see the vaporous cavitation, you know, and exactly where the business end of that ablation is. I do this because I think it helps get it through the FDA. We need to have a knob, right, so you can predict exactly where in the field the ablation is going to occur. And I think we do better predicting that with theory than actually experiments. And the experiments then are done, you know, 5 years, 10 years later in order to see how the theory is, whether it's true or not. So that's essentially been my approach for ablative technology, is to first do the theory and then, you know, 5 years later to do the experiments to see how well our predictions work. We've been pretty good so far. Yeah, so it's a Rayleigh equation, Rayleigh-Placid equation, highly nonlinear equation. Very exciting part of physics to work in, actually, because it's so nonlinear. It's really good.
Thank you.
Sure.
So we will thank again Professor Holland for this wonderful talk.
Thanks.